Good afternoon, everybody. I'm excited to do our first interview for the IS-PEC Center with Dr. Judith Shamian. Dr. Shamian was, as we call, the head nurse of Canada, or the chief nurse of Canada, the president and CEO of the Victorian Order of Nurses in Canada, and pretty much the head nurse of the world with her position in the International Council of Nurses. We're going to jump right in because we're trying to keep these interviews short, even though we could talk for hours about her exciting life experiences and lessons learned. So we're going to just jump right in. Thank you for coming.
You're welcome.
So throughout your career, you witnessed the evolution of nursing policy globally. What do you consider the most critical gap between policy development and successful implementation at the frontline level?
So I don't know if I call it policy development, but I witnessed a phenomenal amount of high quality research that could lead to policy and implementation. But the transition from the knowledge to policy to implementation has been minimal. In my opinion, we can stop today all the research that is done globally and take all the results, and it will take a decade or more just to develop the policies and implement and have the desired impact that these findings can provide.
And why do you think there is that? Why do you think it's not happening?
It's not happening for several reasons. Researchers don't speak the language of policymakers. There is not connection and gap between the two. Also, there is limited presence of scientists and policymakers around decision-making tables, and that all interferes with the decisions. And oftentimes, political and public pressure pushes the decisions versus evidence-based decisions.
Can you share a specific, you say there's so much good research that's not being implemented. We like to look at the positive when we can, those positive deviant studies. Can you share a specific example where you successfully bridged the research to policy at either, when you worked at the local level, at the national level, at the global level?
Sure, my pleasure. And my story and experience goes back to the early 90s when in Canada there was a major budget cut nationally. And of course, when there are budget cuts, healthcare and education suffers the most. At that time, I was vice president nursing at Mount Sinai Hospital, which is a teaching hospital in Toronto. And I run the department. I had a budget of $50 million, and I was asked to cut 10% of my budget, which is a lot. And everybody around in the healthcare system basically slashed the most expensive worker and replaced them with low-paying workers, and that's how they saved the money. By that time, there was research emerging from Linda Aiken that showed that having the right combination of well-prepared nurses leads to better outcome and lower mortality. And I always looked at what's the evidence in making management decisions. So while everybody around me in all of the leading hospitals in the country were laying off dozens, if not hundreds, of registered nurses, I took a plan to my board that basically said, I want to retain and strengthen my registered nursing workforce and save the money in different ways by eliminating lower paying positions. Many of my colleagues looked at me like I was an idiot because how are you going to do it? But I was able to demonstrate to the board and to say that by then the board had a lot of confidence in me because I had a track record of managing well, and they humored me and said, okay. And the end of the story is that we had better clinical outcomes, better retention, lower cost of turnover, and so on, because we went into an all registered nurse employment. And I think it's still the same after 30 years.
So did other hospitals in downtown Toronto follow suit?
No, no. And even for today, which we are entering the 2025, I think Mount Sinai is the only hospital that considered to be a magnet hospital and a leading institution in Canada. So having the right foundation and the right nursing infrastructure allows you to build a healthy environment and a very good organization. And it's all evidence-based driven.
Can you, for our listeners that don't know what magnet hospitals are, can you briefly explain that?
So the magnet hospital is a concept that started in the United States in the 70s when they had major shortages, and researchers realized that some hospitals had no problem in recruiting and retaining, and others just had to shut down because they had no staff. And the factors that they identified, that those magnet hospitals that they labeled magnet had a strong nursing leadership, hospital leadership that was committed to professional practice and evidence-based practice.
Thank you. So you said that your board humored you, but it was really, it sounds more like they trusted you and you had built a relationship over time. And we know from the research that relationships really do help support evidence-informed policy and the process. But what other factors do you think were at play here that made the board agree and made it a successful implementation?
So to your point, I always talk about the art and the science. The science is the evidence. The art is the power factors that you use and the relationship and the information and the communication, and not the moment that you need it, but you build it over time, that leads you to shared decision. I think what convinced also the board is who can argue with the fact that you want to build a better clinical outcome, reduce morbidity, improve morbidity, no, less morbidity and less mortality for the patients, okay? So better health and fewer deceased people. And I had a track record that whenever I took other innovative relationship decisions that were evidence-based, they resulted in a terrific outcome.
Thank you. Can you give us an example, maybe on a global level as well?
So the issue about global level that it's important to understand is that you can prepare the evidence, but whether it will get integrated, into policy and practice, it really depends in the country that makes use of that evidence. And one of the good examples is the commission that I served on at the United Nations that called High Level Commission on Health, Employment, and Economic Growth. And in that commission, there was a whole group of researchers that provided the evidence of how we can build a better health, employment, and better economic growth. The question is, and it was presented in the United Nations for all the heads of states, how many of them took it is questionable. Another example, I guess, that it's relevant to that discussion is the work that we have done with I have done with the World Bank and EXA, which is the East Central South African group of a body that works with those 15 African countries and have regular meetings with the ministers of health, who I met with multiple times, and we presented the data that could be useful to them around the human resource issues. And some of them have taken it and advanced it, others didn't. So in the global level, we have an obligation to share the information and provide the support to implement it. But it's really up to the leadership players at the government level and the service level how much of it get advanced.
Has your thinking in this topic shifted over time? Has your understanding of effective evidence-informed policy or policy engagement, has it changed? And if so, how and why?
I think over the last few decades, there is much more awareness of the importance of evidence. I remember when I started my management career and I used evidence, people looked at me like, what? It wasn't as part of the management roundtable discussion. It is more central to discussions, but I don't think that it's still very central to implementation.
So what do you think we can do about that?
So I think it's fairly straightforward. We cannot have a decision-making table around health issues that doesn't have some scientists and some professionals that know the knowledge and know how to implement those things and give them the right forum to put it on the table and negotiate with decision makers that have also external pressures, political pressures, and so on, and try to come to a happy medium. It cannot be either this or that. It has to have a combination. And I think we have seen that it didn't happen during COVID and during the national vaccination programs. When we did the study of looking at what was the role that nursing played in COVID, and we know that they were very significant. Basically, the majority of the message was that nurses were great in giving all the vaccines. Did they sit around the decision-making table to decide how to do the campaign and how to do it? Only in very few countries. And that's the problem. And that's the solution.
So what I hear from what you're saying and how you started in terms of we don't need to do more research, it's not that there's a lack of knowledge. It's not that we need to create more evidence. It's that we need to really bridge that gap.
Absolutely. We need centers like yours, Professor Ellen, to be able to sit at the right tables. And it should be the norm. It shouldn't be the exception. And it shouldn't be a nice thing to ask Professor Ellen and her team and many others to come and give a presentation. But it should be an expected norm that you cannot have a roundtable for decisions around system and practice level without the right players at the table.
So if I'm a genie and I say, here, you have one wish, one ask, what would it be? What should we do?
I think we need to have every government institute a legal accreditation requirement of the right players at the right table, just like you have in finance departments. They will not make finance decisions without economists, or they will not pass legal laws without having lawyers or experts in law. Why in healthcare it's different? Why we believe that we can have a bunch of people who are well-meaning, can sit around the table and decide on policies that they know nothing about because they don't know the science, they don't know the practice, they don't know the community, and they don't know the reality. Not okay.
I love it. I think you should be the poster child for this. So we're going to end with a one sentence response, if you can. If you could whisper one piece of advice into every future nurse leader's ear, what would you say?
It will be two pieces.
Okay. I'll give you two.
One piece is what Florence Nightingale said several centuries ago, that without making policy progress every day, every week, every month, we're going backwards. Number one. Number two, please, as a junior nurse, open your parachute and look at what's going outside of the nursing milieu, outside of your clinical area. Be aware, have a voice, and get involved.
Amazing. And with that, we end our short podcast with Dr. Judith Shamian. Thank you so much for your time. We will link also to her Wikipedia page so you can read more about her. And if you have any questions, let us know, and we can always conduct a follow-up.